Welcome to the Well Project and our leadership exchange. I am Bridgette Picou. I am a nurse working in the HIV field, and joining me this morning is Mariam. I'm sorry, how do you say your last name?
Davtyan.
Davtyan. Okay, sorry. I meant to ask that in the beginning. Joining me this morning is Mariam Davtyan, who it is my pleasure to be here with. When I decided I wanted to do one of the leadership exchanges, you were actually the first person that I thought of.
Oh, thank
So if you could just introduce yourself, tell us a little bit about you and what you do.
Sure, thank you. It's so lovely to be here. Thank you so much for that lovely introduction, Bridgette. I'm Dr. Mariam Davtyan. I am an assistant professor of research pediatrics at the Keck School of Medicine at the University of Southern California, and I conduct pediatric and adult HIV related research. And my research focuses, I do a lot of different studies, but my research focuses on the effects of HIV medications on exposed but uninfected children. And I also have spent quite a lot of time looking at HIV-related stigma and outcomes related to that experience, and particularly among women of color living with HIV.
And so that is actually how I was introduced to you, was in some of the research studies. We are on a strategic advisory board together. And I have always found your questions to be super thoughtful, which is why I thought about you for doing this. Now, one thing you said that I did not know was that you work with children who were exposed but uninfected. I love that. I actually was at Croy, and they did a whole plenary on exactly those children. And I was surprised to find that there were so many of them, and that there's such a broad range of things that researchers look at in regards to those children. Because really, it's not something that I think the average person thinks of. Like for me, my thought was, okay, great. You know, this mom who is who's living with HIV had a baby, and the baby is not affected by HIV, but there's so much more to it. Can you talk a little bit about that?
Absolutely. Thank you for the question. It's a lovely question. And we're so, grateful that we live in a world where a woman with HIV can give birth to a child, a baby free of HIV. And that happens because we have such effective antiretroviral medications that prevent perinatal transmission. And you're right, we tend to think of, if children are free of HIV, we get excited, fabulous, this is great. But exposure to HIV medications can lead to complications. And what we look at is, growth and development, and language and hearing and cardiometabolic health related to exposure, not to just HIV medications, but also to HIV while the mother is pregnant. And, and these studies that I've been part of have really attested to the safety of HIV medications. And because, while we do see complications in children, I think that it's fair to say that a lot of children, in fact, most children, do pretty well in those different domains that I just mentioned.
Yeah. That's a beautiful blessing. Like, it's just the idea that we've gone from, over the span of 40 years, from this idea that it's a death sentence to finding medications, to developing the medications so they're less toxic, to, mothers, and we've reduced vertical transmission till it's almost, non-existent now, which is terrific. And so that's one of the reasons that I felt like it was so important to get involved with women in HIV, because there's so much that, there's so many ways that HIV affects women that it doesn't affect men. And it's important to kind of shine a light on some of those things. Was there something that drew you towards working with women and children more than anything else?
So I didn't start off working with women of color living with HIV. I initially did my practicum when I was a graduate student with LGBTQ youth. And through that experience, these young people shared really interesting and very upsetting, experiences about living with HIV and also dealing with structural inequalities, intersectional prejudice related to sexual orientation, gender identification, race, ethnicity, income, neighborhood, and it was very upsetting to hear that. And it was also a significant learning experience for me. And so when I finished my master's, I applied for a job and was hired at USC, working primarily with women of color living with HIV, African American and Hispanic women. And, beyond doing, formal research, what I'm grateful for is that in that role, women shared their stories with me. And I consider myself very lucky, very blessed that they trusted me enough to talk about their experiences. And one of those experiences was stigma related to their HIV and how disruptive it was. And so I started thinking that, gosh, we tend to focus on treatment, which is important, making sure that women and people with HIV stick to their medications and adhere closely. But what are we doing about these social determinants of health? Because they are interfering with quality of life. So once I started thinking of those questions, my decision was solid. This is the population that I like to work with, to advocate for, okay? Because if you work in the field of HIV, you must also be an advocate. You must. And so I was beyond persuaded. And so I've been working with this population for 17 years now. So I'm very proud of it, very much so.
That's a good long time. That's a good long time. I was at USCHA and you did a presentation there about your stigma research. I don't know if you remember that. I was asking you questions.
Yes, I do. Of course I remember, very fondly.
Yes, I actually wrote a little piece for the Well Project about that because it struck me. One of the things that you said, I'm trying to remember exactly how you said it. We were discussing that women with better education and support systems do better. But one of the things that you said was about bolstering resources, to bolster your resources. And that struck me because I'm really big on doing the things that build your resiliencies, right? And help you navigate this whole process. Yeah. And so is there something that you can think of that women in general living with HIV should probably pay more attention to or should ask their providers more so about?
Yeah, it's a great question. So in the research that I have done and the research that I have evaluated, I think it's more important for providers to assess these factors in women of color living with HIV. For instance, your social support networks. Do you have anyone who can provide you with emotional support, with instrumental social support? Like a lot of women, talk about childcare as being a barrier to care because women do everything. Women are, caretakers of everyone. And so they tend to put themselves last. Okay. So asking women, do they have childcare services to be able to better make their appointments, right? If they have transportation to actually get to their appointments, right? Things like that. But in addition to the medications that providers prescribe, it's also important to get the whole story. And you spoke about resiliency, and those are such important factors to consider, and they are helpful. So if we fortify patients with things like, if there's a way we can increase resiliency levels, increase mindfulness, increase sense of, personal mastery, which is your perceived control over your lives, right? If we can increase those resources, then, women are less likely to internalize the prejudice that the world perpetrates against women with HIV. They're less likely to internalize that, because internalization of stigma is particularly insidious. It's particularly bad. And that's because it really impacts your self-definition, how you perceive yourself, how you think of yourself, right? So if you think of yourself as tarnished or dirty, and these are the words that have been used by women of color living with HIV to describe how they feel, if it's internalized, then it tends to impact their health-seeking behaviors. They're less likely to go to their appointments, to take their medications, and that could lead to negative outcomes. So beyond the biomedical support, we need a lot of attention to social determinants of health and resilience factors. So I hope that answers your question. I tend to, just go off tangent like a lot.
No, it does. And actually, one of the things that you stuck out to me was putting some of the onus and some of the responsibility back on providers, because I think that's important. I think sometimes as providers, they get into, or we, because I'm a provider, we get into this habit of thinking that because we know the answer and because we've seen this patient, 4 or 5 times, that they know the answer, or that they'll speak up and say what they need. And that's not always the case.
That's right.
So a co-decision making, shared decision making.
Very much so.
Yeah.
Being cognizant of, women's unique educational background, socioeconomic background, and being sensitive to those. I think, and I've said this, and I say this to my students, providers really need to manage their power so that it's an equal field where your patient can feel comfortable sharing things that are going on in their lives. For instance, intimate partner violence, quite prevalent, right? Specifically during the COVID-19 pandemic.
Right.
If you want a woman with HIV to share her experiences with trauma, intergenerational trauma, but also sexual trauma. These are all things that can, inflate a woman's risk for HIV. So creating this safe space where you can engage with your patients, with your clients, but also provide a platform for them to honestly speak to you and confide in you is really, really important. So shared decision-making, assessment of literacy, assessment of social conditions, all of those, I think, can be quite therapeutic.
Yeah. Yeah. And I love the shared power aspect of it, because I've had conversations with women who feel like they can't ask questions because, there's this provider who has all of these letters, and all of this education, and they feel like their question is going to be dumb, or that, the provider's heard it a million times. And, my thing is ask it. It's important to get your questions. Maybe they have, but they've never answered it for you.
That's right.
And that shared sense of power is important, because if I feel invested and I feel like I have some power in our relationship, then I'm more likely to invest in my day-to-day healthcare and, come to appointments. I always say you don't necessarily have to love your provider, but you should at least trust them to take care of you. Yeah.
That's right. To trust and respect. You don't have to like. I think respect and trust are far more important. And I think that's a really great, elegant way to put it, Bridgette. I think that HIV makes people feel disempowered. And that comes from just the way that society still 40 years into this global pandemic, people are still viewed negatively. And so providers should know that people with HIV tend to feel disempowered. Not everyone. Some folks are resilient and don't feel that way. But if you're, let's say, a person who's newly diagnosed, don't really know how to navigate the complex healthcare system, and you may be feeling disempowered, right? And so let's not make people feel even further disempowered by making it difficult to communicate. So I'm very big on managing power. And so, I mean, this goes not just for providers, it goes for academics and everyone who engages with this community to really sit down, check your privilege, and put your power, control your power and allow for people to engage with you, to trust you, to talk to you. I think that we often neglect people living with HIV by not really listening to their unique and nuanced stories.
Yeah. I think like for you and being in research, I think it's a unique place to be, right? And then the benefit that you have, I think, over some researchers is that you do forward-facing and patient-facing interactions too, which makes a difference. What are some of the key lessons that research has taught you about HIV and about people in HIV?
Yeah, it's a great question. Thank you, Bridgette. I think it's taught me about the complexity of risk. I think society thinks of HIV as a personal descent, as personal irresponsibility. And being in research and studying, the disease biomedically, but also from the social perspective, it's taught me to think of HIV as not a byproduct of personal irresponsibility and personal dissent, that everything matters, that sure, your individual behaviors, but what about your networks? What about the community that you live in? What about the policies and the laws in the places that you live, in the communities and the cities that you live? All of those things can play a role in inflating your risk for HIV. So I think we really need to disengage from these antiquated conceptions of disease that you messed up, this is why you have this disease. That's not helpful. That is not therapeutic. We have to think about, being compassionate, being supportive. It's a medical condition, let's not forget. But because of its association with perceived illicit behaviors, somehow we separate it from other things, right? So let's move away from thinking of HIV as people messing up, okay? Because we all mess up, come on, we all mess up. And think of it as, a byproduct of neglect, byproduct of broken infrastructure, byproduct of not addressing people's needs. So research has really illuminated that for me in the last 17 years.
That is an amazing perspective. And I hope people really hear that and listen to that, because it's, the intersectionality, right? And the layers. And you were talking about social determinants of health, which are actually like factors, right? In why people become vulnerable to HIV and why women are vulnerable to HIV. And just reframing not only what we consider risk to be, but also kind of reframing how we look at society overall, how we got here and how we can move on from here. I don't think there's enough focus on how we move on from here. Yes, we know we want to get people in care and get people to stay in care and get people to take their medication and all of that. But I think that especially right now with the racial reckoning and the climate of women's reproductive health, like all of these things require focus and attention right now, because we're in a moment. And if we miss this moment, I think down the line, we're going to be in trouble. I think the strides that we've made are wonderful, but unless we start addressing some of those layering factors, we're going to get stuck.
Right. It's a very reductionistic perspective, Bridgette. If you leave out things like race, you leave out things such as socioeconomic disadvantage. folks living in neighborhoods that are not safe, or folks who have no access to high quality care. Right. Because then we'll just go back to blaming people. Well, you didn't do this, and that's why you're here. But not looking at infrastructure, not looking at policy, not looking at people in a holistic kind of perspective and way, I think you're missing out. You're missing the important factors that can make a difference between this person being able to navigate this world and jump through all of these hurdles that folks need to jump through. We just completely just pretend they don't exist. You cannot do that. You don't have a full picture if you omit those important factors, And one factor that I keep, emphasizing and underscoring is, stigma. It's still intersectional stigma, but stigma related to HIV. And people seem to think that, oh, well, is that still an issue? I still get that. When I present work, I lecture, whatever, people still look at me like, is this still an issue? It very much is an issue,
Very much. Yeah.
And the research shows that, majority of people experience prejudice related to their HIV status. And a vast majority internalize the stigma that they experience. So that's leading to behaviors that are not conducive to health.
Right.
And so you must address HIV related stigma if you're studying HIV. If you're treating folks with HIV, you must also address stigma, in addition to the other, social determinants of health, other factors that could that may be impacting a person's life. So it's a complex picture.
It is. And I think that people who ask the question, is it still a thing? Is stigma still a thing? Are asking that from a place of privilege and a place of power. Because it's not something that you personally have to think about. And so, or maybe, and I think sometimes it's just that people are, they're good at heart. And so they feel like they would never stigmatize someone.
Right.
But they don't realize that a million other people do.
That's right.
There's all these little microaggressions that people don't recognize, that even though you don't think you would ever, you do. So it's important for, especially in research and in care, for people to recognize that stigma is enormous, and it's harmful. And it is one of the main reasons that people don't stay in care or don't come and get care. Yeah.
And I think that the fact that healthcare settings are still prevalent spaces where HIV related stigma, it still takes place, I think that's particularly bothersome to me. And I think you'll agree, because you're a provider, you care for women with HIV, and that's one of the reasons I wanted to have this conversation with you as a provider, right? So we have these unique vantage points, the fact that stigma takes place in healthcare, the fact that we still physically distance ourselves from people with HIV, or, we use these exaggerated measures to protect ourselves, right? Like I've had patients tell me, they've put on 2 pairs of gloves just for, talking to a patient with HIV. The fact that people have put on protective gears, to me, it's unacceptable. It's unacceptable. Healthcare should be a safe haven. It should be a bastion of care, of trust. And, so that goes to what you said, that some people just may not know that their body language, the way they're approaching someone, is being construed as stigmatizing, because stigma can be overt, but also not.
Yeah.
So when we educate our future doctors, our future nurses, our future ancillary support staff, that needs to be part of the curriculum. A couple of years ago, I interviewed physicians, nurses, ancillary health support staff, and they said to me, they said, Mariam, we don't learn this stuff. We're not taught
In school.
manifestations. Exactly. In school, we're not taught manifestations of stigma. Maybe some of them, the very overt ones, perhaps, but we're not told how to conduct ourselves. Some of them said, I don't engage very much with people living with HIV, so I don't know how to speak with someone such that they don't feel alienated, they don't feel a certain type of way. So that, it goes back to making sure that we insert HIV specific, stigma specific instruction in schools so that everyone is aware, right?
Yeah. I know from experience from nursing school that, people get a day and a half of outdated HIV information. I know from personal experience, being seen at certain physicians' offices, like just, a brief, long story short, I had a provider who saw me, who came in to examine me with 2 pairs of gloves, 2 gowns, one facing forward, one facing backward, head covering, goggles. Come on.
Yeah.
And so it's still very much prep. It was one of 2 situations that made me feel like, dang, do I really want to be a nurse? But I had to remind myself to flip that around. And this is exactly why I need to be a nurse, in order to teach people. Right. And we had nursing students that would come through. And the unfortunate thing is that there are a lot of old school nurses who have been doing this forever, who never really got involved in the day-to-day care of persons living with HIV. And so all they knew was the initial stigma and the initial terror, really, because that's what people felt, when they didn't know how HIV was transmitted and all of that. And so, you still have instructors who are teaching people to wear gloves, to do vitals, which is just heartbreaking. But it is important to speak up about those things and try to educate. And just, I tell people all of the time, the best way to deal, if you don't know how to talk to someone with HIV, is just to talk to them.
Ask questions. Exactly. I feel the same way, Bridgette. Ask questions.
Yes.
And one thing, and I think you'll agree with that, when we are developing programs, when we are developing protocols, whether it's for education, whether it's for research, we need to make sure that we include people with HIV in those processes.
Absolutely.
So that it's not just coming from position of privilege.
Yes.
Like a researcher, we need the engagement of people with HIV such that these programs are socially valid, such that they are salient to the community. Like, you can't make decisions about people with HIV without including people with HIV. Can we do that, please? Can we make sure that this vital, amazing community is part of the discussion, is sitting at a conference room with you when you make those decisions? Because then they'll tell you, listen, so in med school, they should teach you the following things. I went through this, and I don't want other people to go through this. So please try to incorporate this vital information into your curriculum. I mean, it sounds simple, but I feel like we're slowly getting there. I feel like community engagement is really becoming much more robust than it once was. You don't want to just, invite the participation of people with HIV as testimonials. No, you want people to be part of the decision-making process, okay?
Yes.
When it comes to education and research and so forth.
Yes, absolutely. We just had a whole big meeting about that and about community engagement and how important it is for us to not just be at the table and not just rubber stamp, whatever you say,
right,
or, put our approval on it. Like, we want to be part from the very beginning of when you set up your review boards and when you set up your processes and when you're coming up with the questions that you want to ask. You want to have someone living with HIV
That's
to
right.
review those questions so that, you know, you can make sure that there aren't microaggressions, you know, contained in those questions.
That's right.
And yeah, I think that the HIV community has a wealth of knowledge that I think sometimes gets overlooked because we're living it. And not only are most of us living it, but a lot of us are doing research on it so that we know what kind of conversations to have. We want to know what medications we're putting in our bodies. We want to know what a T cell and a viral load and a, you know, all of that, what all of that means for our overall health. So I think that people in the community are way more savvy than we get credit for.
Absolutely.
And yeah, and especially at the educational level, when you're a nurse or a doctor, or you're going through what have you, it's so vital to have all of that information so that you can be effective.
Absolutely, I agree with you. I think we tend to underestimate the lived experience. Like, I can read a whole slew of articles and papers, and I have access to these things about HIV, but nothing really beats that lived experience. In fact, in my own training, the lived experience has left a bigger impression on me in terms of what I need to do as a researcher, as a program planner, than all the stats that I read. Now, don't get me wrong, the stats are important, right? These are important things that we need to incorporate, but the lived experience, the stories, the intricate aspects of life that may be unknown to the, you know, to the researcher, that's supplied by people living with HIV. And for that reason, they should have an enormous part in the programs we plan and the research that we develop and implement. One thing I can tell you, Bridgette, and I've seen this like firsthand, you know, when I learned through the research about how, let's say, African-American women, what their experiences are with stigma and how it impacts various aspects of their lives, I realized that in order to address this, I need to have them disseminate the intervention to, let's say, educate, you know, healthcare workers. So in one of the studies that I did, I brought those women and they were the agents of change, not me lecturing, you know, healthcare workers about the perils of stigma, which we know, but I had women living with HIV, women of color living with HIV, come and actually, you know, disseminate that intervention to the healthcare workers themselves. And when I was reading the evaluations for that study, no one said, "Hey, Mariam, your stats were awesome." No, they said, "Gosh, the stories that the women told about their experiences or stigma has provided a brand new perspective on how I view this disease and patients living with this disease."
Yeah,
there's nothing better than that.
that's beautiful. That's beautiful. And I wish there were more. And that's why one of the reasons I think it's so important to have women in these types of roles, to have women in research, to have women be our HIV and infectious disease specialists, and to have women sit at these tables, because we have a unique perspective. And I think that comes from the fact that we are, whether we want to or not, always placed in these roles of being a caregiver.
That's right.
Of always being the problem solver. So we learn how to solve problems.
Troubleshoot.
And
yes.
Yeah. Yeah. So I want to encourage more women to get into research. So are there particular paths that you think women can take to get involved more?
It's a great question. One really impactful way is to be part of a community advisory board. So clinics that provide, or healthcare institutions that provide HIV related services, tend to have a community advisory board. And these boards are, you know, like organizations or groups that consisting of patients living with HIV who provide critical feedback on services provided by that particular healthcare organization. I run the community advisory board at LA County USC. It's called the Maternal Child and Adolescent Center. And this is a group that consists of women of color living with HIV. And, this group meets like 4 times a year and appraises the services, appraises the whatever the clinic is providing to ensure that it is congruent with the needs of the HIV community, that it includes the HIV community, and makes decisions based on those appraisals. So women can, one way to impactfully participate is to be part of these CAB groups or community advisory boards. I think it's really, really important.
Yeah, definitely. I also like the idea of women becoming peer navigators and getting involved in positions at clinics and hospitals so that they can help people coming in who may not know the healthcare system or know their way around clinics and things like that, to be able to help with that. Because again, lived experience is the best experience. And I think we people get shy at the idea of being an advocate, but every time you advocate for yourself, you're advocating for the next person behind you, because sometimes it gives a perspective that maybe the clinician has never heard, and it sticks with them, so they have that for the next time they come into contact with a person living with HIV. So yeah, I'm on the CAB for the Well Project, and it is one of my favorite experiences, because you do get to you learn things that you can then take back to the community that can impact the community. Definitely, yeah.
And also through these groups, providers relinquish their power. They give the power back to the people whose lives we're trying to improve, right? But we're including them in that protocol. We're including them as part of that process. It's really, really important. You mentioned peer navigators, incredibly important, like a buddy system. I know at our clinic, we had this a while back, a buddy system pairing, let's say, newly diagnosed woman with someone who's been living with HIV for a long time to help them navigate the healthcare system, to help them sign up for services and explain the medications and provide other resources. So there's so many different roles that women with HIV can play to be advocate. You don't always actually need to be allowed. If you're shy or embarrassed, it's fine. It's very human. You don't have to be in the forefront. You could be writing a letter. You could be being a shoulder for someone. That's activism too,
Yes, absolutely.
By being a support system for someone who's living with this terribly stigmatized, disease. So yeah.
Those are great points. And it brings to mind, like, I remember when I first went to my my ASO, my AIDS service organization, they had all of these men telling me that I was going to be okay. And I'm like, right. Okay.
Thanks.
Thanks so much. And so I think that it's important that we remember that we need the faces to match the faces, right? Because a woman telling me that I'm going to be okay is much more impactful than a man telling me that I'm going to be okay. And a woman of color, Black woman telling me that it's going to be okay, she's been where I'm at, is, even more so impactful. So I think that that's a thing that we need to keep in mind too, is that it's great to have support, but the support should look like, walk like, talk like, and have the same experiences that I have, so I can identify.
So you can relate, so you can continue to go back. And that goes to show about, when we think about hiring staff members and diversity and inclusion, to ensure that that the representatives of our healthcare institution are representatives of the communities that we serve. It's an excellent way, an important way to build rapport. Rapport is needed. When you work with people, you need rapport. And so by being inclusive and being diverse in your infrastructure, you are maximizing the likelihood that these folks will come and these folks will stay.
Yes.
You want people to stay
and be engaged in their care.
Right. And if you go there and you feel like, listen, no one understands, no one looks like me, no one understands where I'm coming from, you know, it may impact whether you return for your second appointment. And
Exactly.
so those things, everything matters. I always say everything matters.
Yes.
When it comes to, you know, engagement with the HIV community. So
yeah.
Bridgette, can I ask you a question?
Yeah.
Since you're a provider and a champion for women of color and women of color living with HIV, what's been like, what's the hardest part of your job?
You know, I don't want to say I'm an empath, but I get the imprint of people's emotions. And I think the hardest part for me is when I know someone is on the brink of giving up.
Mm-hmm.
You know, I can tell their numbers are changing, you know, because I see their labs. I can call the pharmacy and I know they're not picking up their meds. So the hardest part is really just trying to keep people encouraged, and keep people knowing that, you know, where you are is not who you are. And it's a moment right now. Like you're having a moment. We get pill fatigue. We get appointment fatigue. We get caught up. And I think this is a problem for women in particular. We get caught up in our numbers. We want our CD4 count to be the same as, you know, this person over here. And the reality is that it may never be.
Mm-hmm.
And so for me, the biggest thing is trying to keep people encouraged. Yeah. I live by affirmations. It's ridiculous how many I have, but it's what keeps me going, right? It's what I do. I do affirmations until I know what I'm actually going to physically do. But one of my favorite affirmations is, if you can't find the light, be the light. And so my goal is to always try to be a light for someone so that I can get them into that next appointment, so that they will continue to take their meds. So the next time they come in, their numbers go up and we're back on track. So I think that's what it is for me.
That's beautiful. Thank you for sharing that. Always curious. Yeah, of course. I'm always curious about what healthcare workers experience and some of the difficulties they face. And I think
burnout is huge.
Yeah.
Yeah. You know, with COVID, it just kind of, and for a lot of patients, COVID was traumatic because it reinforced, you know, a lot of that isolation, the feelings of isolation and loneliness, which, you know, along with stigma, you know, are huge. And so, it's not always easy, but at the end of the day, it's always worth it. Like it may not be that day, that one day I may go home and cuss and fuss and be ready to quit, but then then I wake up the next day and I'm like, okay, I can do this again. So
it takes a daily reminder. And I think I love what you said about, you know, affirmations. I think it can get overwhelming. It can get upsetting. You know, patients have died, patients experienced, you know, so many different traumas. It gets to you, you know, and you find yourself just emotionally, I don't know, spilling over is the best way I can describe it. But like, I remind myself to be grateful and just express my gratitude at the privilege I have. And doing research, yes, but also the privilege to be the recipient of these stories and how important they are and how much they can frame healthcare. If everyone should be so lucky to get these lived experiences of people, because I think it would make healthcare a very digestible place because it can be a scary place, but a digestible place and a place where people feel okay, they feel safe.
Yeah. And I think that is one of the main things that would that keeps us, and not just the patient, not just from a patient perspective, but feeling like it is a safe space is really, really important. And we have to go out of our way to make sure that it is, so that people continue to be in care and are engaged. There's like, there's so many questions I still have that I want to ask you, but we're like getting so close to time. I'm gonna try to pick one.
Okay. I can talk about this all day.
Right,
All day,
exactly.
every day.
You know what? I'll ask this because I know that we have a lot of women that have children that come to the Well Project and use the resources. So, is there an age that you feel like children become aware of stigma, and how does it kind of shape or have the potential to shape their adulthood?
So the majority of the children that I work with don't are exposed but uninfected, and so we deal with the parental stigma, right?
Yeah.
The experiences that the parents feel. I can tell you that stigma prevents parents from disclosing their status to their children, and when they do, children kind of react differently. Some are terrified they're going to lose their parents. So even at the young age, they associate HIV with death. So they think that their parents are going to die. But there are also reactions that are supportive, like I'll help you stick to your meds. I'll help you do this and that. So they react differently to this parental disclosure. In terms of understanding what stigma is, I'm just going to guess here, but there's a certain level of development necessary and maturity level necessary to understand how stigma actually works. And I think that comes with age. And I think that, for kids who are living with HIV when they're younger, they may not understand, they may not know how this manifests, they don't know how this is internalized. But unfortunately, they will find out because this is an incredibly cruel and judgmental world. And I think what we need to think about is, we know this stigma is going to be experienced. We know this stigma is going to be internalized. So what can we do to help these kids when they are of age to have better outcomes, right? And so I would say social support is really important. Cognitive behavioral therapy may be really important. Like I said earlier on, fortifying these kids with resources, mindfulness-based activities, resilience-based activities. If we start early, then when they do experience, it may not lead to such horrible consequences,
Yeah.
So I'm just kind of guessing here because I haven't really worked with kids too much with kids with HIV, but it takes time to understand it. I mean, adults barely understand it. I mean, like a 13, 14-year-old may just not really be able to conceptualize it, but they will, if they are living with HIV. I mean, based on the statistics and stories we've heard, these kids will experience prejudice. It's what happens after that matters, right? So let's work with these kids. Let's work to ensure that they're not detrimentally impacted by the stigma that they experience.
Yeah. One of the things that I've always found fascinating about HIV and stigma is that there seems to be this hierarchy that people have for how they address stigma. Like they tend to be more sympathetic if you're born with HIV than if they think you engaged in some sort of behavior. And it's very frustrating to try to make people understand that on this side of it, once you start living with HIV, it doesn't matter how I got it. It's the same, the process is there. How I heal is impacted and affected by how I acquired it. And the steps that I take to get healthy are impacted by affected by how I got it. But at the end of the day, HIV is HIV. I'm living with it, or I'm thriving with it,
Thriving with
is
it.
the goal, you know,
Mhm.
or I'm just surviving, which is my goal. I don't want anybody to just survive. I want people to thrive.
I agree with you. I had a patient say I'm managing, and that makes me pause. It gives me pause. I don't want you to just manage. I want you to thrive.
Yeah.
And these are the teachable moments. These are the moments where we need to intervene. Well, why do you feel like you're just managing? What's happening? Let's
Yes.
take the time and talk about, you know, if we're not meeting your needs in a certain way, you know, it may not be about HIV, and many times it isn't about HIV. Like, listen, I'm not able to pay my rent, you know, I'm depressed and I don't have enough mental health services.
Exactly. Yeah.
Yeah. And going back to what you said about mode of transmission and people's reaction, I talked to young adults, and some of them, you know, acquired HIV perinatally, some of them transfusionally. And so when you ask them about their stigma experience, you know, when they say they have HIV, it's that usual, you know, the eyebrow goes up, like this person probably engaged in something illicit. This is their feelings I'm describing. But then when the person in question says, I was born with it, then it's like the sympathy comes in.
Exactly.
Similarly,
Yeah.
I have HIV, eyebrow goes up, right? But then the person says, I acquired it when I was 5 years old in a hospital, anemic, and I needed a transfusion. Then people change their course, which I find it's, you know, it's so upsetting to me. It makes no difference whatsoever. It should never make a difference. It's a medical condition. What are we doing?
Exactly. It's one of the Well Project champions, Maria, always says it's a human condition. And it really is. It's a human condition. It's manageable. It is treatable. But
Yes.
like you said, I don't want it to just be manageable. I want people to thrive, and be bright and walk in their purpose. So.
Right. I agree with you. It's a beautiful way to put it. Thank you.
Yeah, this was a wonderful conversation.
So much.
I'm so glad that you agreed to do this.
How could I not? It's you asking me. I mean, come on. You are an exceptional woman. You are a champion. You are an advocate. You are a rock star. And when a rock star like yourself comes to me and asks me to do something like this, there's no thinking involved. So of course.
Thank you, thank you, thank you. So I'm gonna have to figure out some ways for you to get involved with us at the Well Project, because I sincerely mean it. I love your perspective, even just in this last few minutes. You know, you've given me a couple of different ways to look at something, which is what I always get when I interact with you. So I appreciate that.
Thank you very much. Always available to help.
Certainly. All right. Well, have a wonderful, wonderful rest of your day. Okay.
Likewise, Bridget. Take care.
Thank you.
Thanks.